My name is Michael Brady. My pronouns are he and him, and I'm the National Advisor for LGBT Health at NHS England and NHS Improvement. I also am a clinician. I work as a sexual health and HIV clinician at King's College Hospital in South London, and I'm going to be talking about LGBT plus health inequalities. Not surprisingly, I'm going to be talking a little bit about the causes of the inequalities, some brief overview of some of the main inequalities that we know about, and then finish off thinking about some of the solutions for both things that the system or organizations need to do to address health inequalities, and also some things that we as individuals can do relatively simply today or tomorrow to improve the experience, the access and the outcomes for LGBT plus communities. Now I have somebody very ably moving my slides for me, so thanks to Khan for doing that. We had a little bit of a technical issue to start with, but I'm sure we'll make a great double act. So I've got a couple of slides to start with, which are really just kind of context setting and things that I think we need to keep in mind when we're thinking about the equalities agenda for LGBT plus communities. And it's fair to say at the starting point that we have made some progress in the UK towards LGBT equality, but I purposely put the T in brackets here because I think the experience of trans and non-binary people, the level of equality is not the same yet in this country for trans and non-binary and gender diverse people. Certainly hasn't progressed as much as it has for lesbian, gay and bisexual people. So it's a reminder that when we're talking about LGBT or LGBT plus communities, it's a very diverse community with a range of sexual orientations and gender identities within there, and they're not a homogenous group with a single experience, nor with a single solution to address their health inequalities. So despite that progress, it is still fair to say that pretty much across the board, LGBT plus people still face considerable barriers to leading happy, healthy and fulfilling lives. Discrimination, bullying and harassment is still far too common, and in fact increasing. We're certainly seeing rates of hate crimes, LGB or transphobic hate crimes are rising in this country, and we certainly can find evidence of this in pretty much every setting that we think about, in education, at home, at work, unfortunately still to a certain degree in healthcare, on the streets and in the media, and perhaps particularly in the media, where with certain areas of the media, and particularly social media, it is not hard to find, particularly transphobia being very rife. And this is all sort of context setting. This is defining the lived experience of LGBT plus people, and that does obviously impact on their health, not just their mental health particularly, but also their health seeking behavior. And I think it's also important to keep reminding ourselves that the workforce, the NHS workforce, and certainly the LGBT plus workforce, experience this same environment as well and are having these kind of pressures on them. And so it's important for us to keep thinking about our colleagues as well as our patients. So when we think about LGBT plus health inequalities, it's pretty much fair to say, probably with some very few and very rare exceptions, that pretty much across the board, wherever we have any data, people from LGBT plus communities face greater inequalities when compared to others, and that's whether you're looking at satisfaction of healthcare, whether you're looking at access to healthcare, experience of healthcare, and outcomes from healthcare. And like all marginalized and disadvantaged groups, this has certainly been highlighted and exacerbated by the COVID-19 pandemic. So on the next slide, I'm just going to run through my second bit of context, a reminder for us all, I think, which is about intersectionality, and a reflection or a reminder that none of us are walking around with one single protected characteristic or one single experience. We're all a rich, amazing, diverse mixture of our upbringings, of our race, our ethnicity, our sex, our gender, our sexual orientation, whether or not we have a disability, what jobs we do, what kind of education we have, how much money we earn. So we're complex beings, and that concept of intersectionality is really important because it's that combination of factors that come together to create both the discrimination and inequalities that people experience, but also the privilege that many of us experience or have as well. So whilst we're talking about LGBT plus, it's important to remember that within that umbrella, there is a huge amount of diversity and intersectionality. and our sexual orientations and gender identities interplay with other characteristics as well, and we need to take those into consideration when we're thinking about marginalized or disadvantaged communities, and also make sure that our equalities approach, if you like, is not siloed. So we're not just thinking about race today, or we're not just thinking about disability tomorrow, and we're not just thinking about trans people on Friday. We're remembering that everybody has a complex mix, and all of these factors have a role to play and can be expressed or important to different degrees at different times. So that's my second bit of context, if you like. And then on the next slide, I'm just going to run through just some headlines around health inequalities. In the interest of time, I'm not going to go into all of these in a huge amount of detail, but it's just to give you a little bit of a flavour before we move on to think about some of the potential solutions. So I start with mental health because it's probably the single area, if you had to pick an area, where we see the greatest inequalities. Every form of mental health illness or disease, depression, anxiety, psychosis, suicidal ideation, eating disorders, etc., are all worse in LGBT plus communities, and this is commonly the case. Again, going back to that diversity of the LGBT plus umbrella, frequently the experience of mental health problems is worse for trans and non-binary people when compared to lesbian, gay and bisexual people, and the experiences of all of the community are worse when compared to heterosexual or cisgendered people. So the first couple of circles you can see there both come from the Stonewall Health Survey. Frequently we need to go to the community charitable sector to find data, and I'm going to touch on this again a bit later on, and that's really just because we're still not great across the whole of the NHS about collecting information, whether that's in clinical data sets or in academic research studies. We're not good at collecting data systematically about sexual orientation and gender identity. So frequently when we look at sort of official reports, research studies, clinical output evaluations, we don't see any data on LGBT plus communities. So often we have to go to the voluntary sector for surveys, and Stonewall have some really useful ones. This is the Stonewall Health Survey. I'd encourage you to have a look at it if you have time. It's from a few years ago now, 2018, and there, from that 52%, so more than half of the respondents, and there were about 3,000 respondents, this reported feeling or experiencing depression in the last year. When thinking about younger LGBT plus people, nearly half had reported self-harming in the last year. Going back to that point that I was making, that frequently trans and non-binary people's experience is much worse than that of those who are lesbian, gay and bisexual. So 46% of trans respondents had thought about taking their life in the last year, compared to 31% of LGB respondents to the same survey. So mental health is a significant area to consider. Experience surveys, again, we don't have a huge amount of data. We're starting to get more data as we increasingly ask questions of respondents about their gender identity and their trans status, but where we've done that, well, for the first time in the most recent GP patient experience survey, we asked questions about gender identity and trans status, and the same questions are going to be going into other patient experience surveys over the next year or so. The GP patient experience survey, I think, is important because it's the largest of the NHS patient experience surveys, with around 850,000 responses, and I think from the most recent one, there were nearly 5,000 responses for trans and non-binary people. And as I say, that's the first time we've had that data, but pretty much across the board. And not interestingly, and I don't have time to go into a huge amount of detail, but not every question was worse for trans and non-binary people, but pretty much, or nearly all of them, were reporting worse experience of primary care. And from the same survey, trans and non-binary people particularly, and actually LGBT plus people as a whole, as a community, were more likely to report loneliness, more likely to report frailty, more likely to report living with a chronic illness, and that was because there was a significantly larger proportion who were reporting living with chronic mental health problems, which pushed the chronic illness data up. In terms of sort of healthier behaviours, again, we see this both from research studies and from pretty much all of the surveys, and it comes out in the GP patient experience survey as well. LGBT plus people are more likely to report unhealthier behaviours, if you like, so more likely to be smokers, more likely to report alcohol or other substance misuse. Now, I go back to the point that we're not great at data, so we don't have a lot of data in chronic illnesses and diseases, but where we do, there is some evidence that some chronic illnesses are more common among lesbian, gay and bisexual people. But it kind of stands to reason, I think, that where we see, for example, the much higher rates of smoking amongst LGBT plus communities, it kind of stands to reason that we would expect, if we looked for it, to see higher rates of smoking related illnesses further down the line: lung disease, lung cancer, heart attack, strokes, and so on. Another consistent theme from surveys is in this experience sense is that about 25% of LGBT plus respondents report a lack of understanding from healthcare staff, and that speaks to another area that I'm going to mention around training and workforce development that we need to focus on to improve the experience of LGBT plus people. And all of this pretty much, plus the sort of contextual lived experience things that I was mentioning at the beginning, leads us to the final circle, which is that this is consistent across most surveys. Around about 1 in 6, 1 in 7 LGBT plus people actively avoid accessing healthcare for fear of poor experience or for fear of discrimination, and therefore are more likely to not get the services they need or to present later when conditions are more advanced or perhaps more complex. So those are just some broad thoughts about some of the key inequalities, and we'll move on to the next slide just to say a little bit about healthcare staff. Now this comes from another Stonewall survey called Unhealthy Attitudes, and if we just click through, this is animated a little bit, you may as well just click through to show all of the images on this, Khan, if that's all right. So from the there we go, you can stop now. Thank you. So from this survey, this was of about 3,000 patient-facing health and social care staff. They found that 1 in 4 had heard colleagues making homophobic or biphobic remarks. About 1 in 5 had heard colleagues making transphobic remarks. About 1 in 4 of lesbian, gay and bisexual staff said that they'd been bullied or discriminated against by colleagues, and we see that being picked up in the NHS staff survey. So the staff survey for some years has asked about sexual orientation. It hasn't until the most recent one asked about gender identity and trans status, but we now do have data from that. But we see certainly for lesbian, gay and bisexual staff from the NHS staff survey that pretty much across the board their experience is worse than their heterosexual peers, and they're more likely to report discriminatory behaviour, harassment, bullying, etc. in the workplace. So again, from the Stonewall survey, 3 in 5 of those respondents with direct responsibility for patient care didn't believe that sexual orientation was relevant. About 10% had heard their colleagues express the belief that someone can be cured of being lesbian, gay or bisexual, and that rises to about 20% in respondents from London. Nearly a third of doctors said that they weren't confident to meet the specific care needs of trans patients, and about 1 in 6 said they didn't feel confident to meet the needs of lesbian, gay and bisexual patients. So all coming to say that we've still got quite a lot to do about culture and quite a lot to do about education and training to develop the confidence and the knowledge and the skills of our colleagues across the NHS. So moving on to the next slide, that's some of the issues. Now then some of the solutions, if you like, and I'm going to talk mostly about the first 3 bullet points. These are the 4 kind of areas, priority areas, if you like, of our work programme at NHS England, and they're also the things that I would encourage the system, however we define that, but certainly organisations like trusts, like upcoming ICSs, ICBs, whoever's responsible for delivering or commissioning healthcare, and us as individual healthcare professionals. these are things that we should be thinking about in terms of improving the experience and the outcomes for LGBT plus people. So I'm going to talk a little bit more detail about monitoring and data collection, training and workforce development, and delivering LGBT inclusive services. I think the other area that we mustn't forget about it is our colleagues in the workforce, and there's more to do, as I've said, looking at data, for example, from the staff survey, to make the workplace more inclusive for LGBT plus staff, to make them feel confident, to make them feel welcome, to make them feel able to be their true selves at work, and to address the negative experience around LGBT phobic remarks or discrimination, harassment or bullying that people experience. And I think the workforce thing equally shouldn't be separated from the patient thing, because organisations who are truly inclusive for their LGBT plus workforce will be providing more inclusive services, I'm sure, for their LGBT patients. But as I said, in the interest of time, I'm going to focus on the top three today. So on the next slide, we're going to just think a little bit about monitoring and data collection. And I've mentioned already that one of the challenges, I think, around addressing LGBT plus health inequalities is the fact that we still don't systematically collect information in every clinical data set and in every setting on sexual orientation, gender identity and trans status. And the reason that's important is that until we do that, we won't fully understand the breadth and the depth of the inequalities that these individuals and communities feel or experience. Until we do that, we won't be able to measure the impact robustly of anything that we do to make a change, because we don't have good sort of starting point benchmark data. And also, I think the other important point about asking these questions is that it's important not just for an organization or for a system or on a sort of a population level. There is an individual level benefit to asking questions about sexual orientation, gender identity and trans status. It's a way for services to be more inclusive and to communicate to these communities that they're seen and they're welcomed and that these services are for them. And by which I mean that if you're a patient, for example, who goes and registers at A&E or registers in primary care, or if you're a new member of staff that started to work for the NHS and you get given your registration form or your new staff starter questionnaire, and you're a trans man, for example, or you're non-binary, and you're presented with two boxes to tick which just say male and female, already, even before you've accessed that service or you've started work with that employer, that service and that employer is saying to that trans or non-binary person that we don't see you, you're not included, you're not recognised, you're not counted. So by asking the questions, we are communicating the absolute opposite. So I think the asking the questions is impactful, important, both for the system and for individuals. Now, we do have a national information standard from NHS England and NHS Digital on collecting information on sexual orientation. It's not mandated, but certainly within that there is guidance on how to ask the questions if you're going to collect information on sexual orientation. And that information standard is really why we have seen progress on data collection around sexual orientation. It's in all of the NHS experience surveys, in the staff survey, and slowly is coming into more clinical data sets. But it's fair to say that we're much further behind on asking questions about gender identity and trans status. Exists in very few clinical data sets. We collect this information in sexual health services and HIV services. The questions have recently gone into the mental health services data set. So we're slowly making progress, but it's much further behind than where we're at around sexual orientation. And as I said, in the last year, it has started, these questions have started to go into patient experience surveys. So they're now in the GP patient experience survey, the cancer patient experience survey. I think they're going into the community mental health survey, and they're already in the staff survey. So we're getting there, but we're not nearly at the point where it's all great. And then the other challenge is it's not just about putting the question in the data set or on the IT system. There is a hearts and minds issue about ensuring that staff are confident to ask the questions and that patients are confident to give the answers, and that they know why we're asking the questions and how that information will be used and how that information will be protected. If you want to find out more about this, I would encourage you to look at the LGBT Foundation's website, lgbt.foundation/monitoring. We commissioned them to publish this report, If We're Not Counted, We Don't Count, which has got lots of information about how to ask questions around sexual orientation and gender identity, why it's important, what the impact can be, how we can support staff, and how we can support patients and service users to feel comfortable to ask the questions and to give the answers. So that's monitoring and data collection. The second point I wanted to talk about is training and workforce development. If we move on to the next slide, thank you, Con. I've mentioned from the Stonewall Unhealthy Attitude Survey why this is important, or one of the reasons why this is important. The other thing that I would say is that pretty much consistently in every experience survey where we ask LGBT plus people what would have made your experience better, the single commonest top answer is pretty much always training. If only the receptionist or the nurse or the doctor had been better trained to understand LGBT health inequalities, or feel comfortable asking me questions about my sexual orientation or my gender identity, or didn't assume that the same-sex person that's in the room with me was my brother or my sister when actually it's my husband or my wife, or felt comfortable to use the correct pronouns that I use. So there's a lot I think that we can do in terms of training, as I said, to best so that staff across the board better understand the inequalities and feel more comfortable communicating in simple ways with LGBT plus communities. And it's often relatively simple things, challenging what still remains a very heteronormative and cisnormative approach across healthcare, and being gender affirming, gender inclusive, comfortable using people's correct names and correct pronouns. And whilst we do have some bits of good training, it's really not embedded or systemic enough, and we need to be thinking about it across both undergraduate training and postgraduate training. We think about it in our induction. I don't know what it's like at your trust, but certainly I will say at my trust, when we do have obviously an EDI e-learning module that we do regularly, but it's really not great, must be said, when we're thinking specifically about LGBT plus issues. And e-learning has its place, and it's important and it's simple, but it's often very tick boxy. I don't know about anyone else, I often just skip to the end and do the quiz, if that's an option. So we need to be thinking on building on e-learning, using that as a foundation, but thinking about more in-depth training, such as face-to-face training, and making sure that that training is informed and ideally delivered by LGBT plus people, by engaging with, for example, LGBT networks to support the delivery of that, or engaging with LGBT charities and voluntary sector organisations who are often very happy and very keen to support training. And the other thing that I would say is, and this is why I have these pictures on this slide, is that we can all educate ourselves, and I think that's one of the key components about being an ally to the LGBT plus community, by just reading around the topic. These by no way obviously are the only books, but these are some of the books that I've read in the last few years, which I would very much recommend, particularly, and I have no commercial interest in this, but particularly Gender Explorers by Juno Rose, which is an amazing book. It's really thin and easy to get through, but it's full of really moving and powerful interviews with young trans children and adolescents and their siblings and their parents and carers. It's very moving, and I strongly recommend it to you. So that's another recommendation, training and workforce development. Again, something that we can do as individuals, but also we need to be thinking more about improving as organisations and systems. And then the third one that I just wanted to say something in a bit more detail on the next slide is about delivering inclusive services. And this is really about stepping back and critically and objectively thinking about how inclusive are the services that we provide. Do LGBT plus people recognise them and recognise themselves in our services, and do they feel welcome and included, and that those services are relevant to them? And this again is something that is relatively simple to do, and is also something that both a system or an organisation can do, but something that also we as individuals can do tomorrow. So it's thinking about what kind of imagery are we using? What do the pictures look like on our websites or in our patient-facing information? Do we include trans and non-binary people? Do we include same-sex couples in that information and in that imagery? What about the language that we use in, again, websites or patient-facing information? Is it binary? Is it gendered, or is it inclusive and non-binary in relation to gender, particularly for those services which often are very gendered, like maternity services or cervical screening services or sexual and reproductive health services? If those only use the word woman or woman services, then that is excluding of other people who need those services who also have cervixes or a uterus. Think about what's in our waiting rooms. You know, very simple signs and signals can make a massive difference for LGBT plus people. Having posters on the walls for LGBT plus organizations, or health promotion for LGBT plus communities. So, for example, having something promoting cervical screening in trans men, wearing rainbow lanyards or rainbow badges. These are all things that the vast majority of service users probably wouldn't even clock or register, but make a massive difference to communicating to LGBT plus people that they're seen and welcome and included. And there's some interesting qualitative data, evaluation data from a project called Pride in Practice, which is run by the LGBT Foundation, who go into primary care services and support them to be more LGBT plus inclusive. They do training, they look at their policies, and they explicitly think about these kind of signs and symbols. And evaluation of that project from patients and service users of those primary care services who've gone through the Pride in Practice program have said that seeing those symbols, the poster, the lanyard, the badge, made them feel more comfortable and confident, and improved the clinical consultation they had with the doctor or the nurse, kind of irrespective of what they went in to the surgery for. And then the final thing I think is just to say about the use of pronouns. Again, a very simple signal and sign to trans and non-binary people that they're seen and you're inclusive. So putting them on your badges, putting them in your email signatures, putting them on social media if you use social media. Again, it's a very simple way to communicate inclusivity. And then on the next slide, I just want to say something a little bit extra about pronouns and the use of correct names. There is some data, and both of these studies are from the States, in young trans, non-binary and gender diverse people, showing that there is a positive impact on mental health of using the correct name and the correct pronoun. So the imagery on the left is a study, again, as I said, of trans and non-binary young people that noted that for every one increase in setting where correct name, gender and pronouns was used, there was about a 50% reduction in suicidal ideation or behavior. So in other words, if it was used in the home, so if it wasn't used at all, let's say there was a certain level of suicidal behavior or ideation. If it was used in the home, that was reduced by 50%. If it was used in the home and at school, that was reduced by another 50%. If it was used in the home and the school and with friends, that was reduced by another 50%. So the more it's used and the more places that it's used, the better the mental health of gender diverse children and young people. And similarly, there's another study on the right which showed that suicidal attempts halved when in the group in this study where correct names and pronouns were used. So simple things, using the right names, the right gender and the right pronouns, does make an impact on mental health, on serious mental health such as suicidal ideation and suicide, as well as general health and well-being. So moving on to the next slide, I'm going to just say a little bit, this is a little bit of shameless self-publication, publicisation, that's not even a word, is it? Anyway, about the Rainbow Badge Project, because I think this is a really great example of a bottom-up project that actually is making a difference to the experience of LGBT plus people across the country. Now, the Rainbow Badge Project, as you may well know, was started, I think it's just a couple of years ago, at Guy's St Thomas's Hospital in London by an amazing, enthusiastic and energetic consultant paediatrician called Mike Farquhar. And it started off as a pledge, so an individual signed up an individual pledge to be a good person, to talk about issues relating to sexuality, sexual orientation or gender, to to work or to work towards working in an environment that's open and inclusive, to commit to help and signpost LGBT plus people to support and resources they might need, to act as an advocate, and to help to break down barriers. And within about 18 months, I think, of the project launching, over 2/3 of trusts across the country had signed up, and over 250,000 staff were wearing the badge, and that's increasing. So that's been amazing, but we at NHS England were keen to support that and move it on to the next level. It was getting increasingly hard for Mike to manage this alongside his day job, so we have recently commissioned what we're calling phase 2 of the Rainbow Badge project. Phase 1 still exists, but we're now moving on to phase 2 to address all of those issues that I've talked about, and to really focus on those priority areas that I've mentioned. So on the next slide, you'll see a little bit of information about this. So basically, phase 2, I've already said this, press it again, Khan, if you will. So that's just really showing the range of badges and lanyards that exist in trusts across the country. And I've made that point already about, the majority of trusts and over 250,000 NHS staff are now signed up. So phase 2 is really taking the initial pledge-based approach to a more organisational change approach and a benchmarking quality assurance approach. And we've commissioned a partnership of organisations which is led by the LGBT Foundation, but includes Stonewall, LGBT Partnership, Switchboard, and GLAD, which is the Association of Gay, Lesbian, or the LGBT plus doctors and dentists. And essentially what they're doing is working with individual trusts in a range of areas to get an organisation and culture change, building on that individual commitment that people made with the first phase of the Rainbow Badges. So it's working with trusts on the policies that they use, on the culture that they have, on the education and training that they deliver, on the experiences of the staff, on whether or not they do sexual orientation monitoring, gender identity monitoring. And they go through a process, and then they get awarded a gold, silver or bronze award. And we've purposely made these awards quite difficult to get. So I think you have to get 90% to get a gold. I think it's over 80% to get a silver and over 60% to get a bronze. And if you move on to the next slide, I think we've got there's a little bit more detail about what's assessed. I've mentioned a lot of this already: leadership, policies, monitoring. We do some work in particular areas where we know it's relevant, or there's particular relevance, maybe around language or inclusive services, such as fertility oncology, labs, sexual health, gynecology, mental health. We look at the facilities, gender neutral toilets, all that kind of stuff, how well the organisation engages with this network and with the local community and local voluntary sector organisations. So it's a complex project. And then the next slide, I think, will tell you about the first 10 trusts who went through the first phase of the pilot and were awarded their awards just before Christmas. We had one silver trust, which is really impressive. The bronze trusts are really impressive. There's no sense of anything negative about that. All of those bronze trusts are head and shoulders above many trusts across the rest of the country. This group of 10 were a little bit disadvantaged, I think, because they went through the first phase of the pilot project, which was a little bit short, so they didn't have a lot of time to make what sometimes takes time to change. So we're going to go back to the trust in another year or so's time to see if they want to be rescored and regraded. And in fact, I think one of the trusts, Devon Partnership Trust, is rocketing ahead, has already asked us to reassess them and see if they can move up to a silver. If we move on to the next slide, I think this is just the point that I'm trying to remember what I put on the next slide, but that was the first 10 of the pilot. Oh yeah, this is my summary slide. So I'll just finish one more thing on the Rainbow Badge project. We've now expanded it and have recruited a further 40 trusts, which takes us up to 50, and we've, I think, I don't want to tempt fate by saying it, secured the budget to expand it by another 60 trusts next year. So by 2023, we should have this project in 50% of hospital trusts across the country. And your trust would be very welcome in that if you're not in it already. I don't actually know who's in the most recent trust. Are you nodding? Are you in it? I can see Khan nodding. You're in it. Great. Welcome to the Rainbow Badge Phase 2 family. All right, just a little bit of a summary, and then we'll stop and have some time for questions, hopefully. So just a bit of a summary. One of the key things, I think, is be an ally. We can't make these changes and address these issues by ourselves. The LGBT plus community can't do it by themselves, so we need allies, and there's many ways that you can be an ally. Challenge bad behavior, teach yourself about things that maybe you don't know about, read around the subject, think about your personal practice, how you interact with your colleagues and your patients, so that you're taking an approach where you always respect and respond to the individuality and the diversity of both your colleagues and your patients. Think about how inclusive your care is, or what you can do to make your care more inclusive of LGBT plus people. I would say that all of us have something that we can do to be more inclusive, and a lot of those are changes that we can make very quickly and without any funding. Co-production is essential. Engage with LGBT plus individuals, consult LGBT plus networks or local voluntary sector organisations or national ones. They're very keen to support. They're very keen to move this agenda forward. So look for local or national organisations that can help you with your work, and challenge and call out poor behavior. And if you see it, it's not banter, it's not funny. Those jokes are hurtful and make a significant difference to people's experience. So if you see it, you hear it, challenge it. Make a zero tolerance policy mean a zero tolerance policy, and ask the questions, and by which I mean thinking about some of those things: monitoring, training, inclusive services. You might not be the person who's in charge of the data collection, or who's in charge of the training, or who's in charge of the website, but if you see surveys or data collection that's not inclusive of LGBT plus people, or you see training that is not really well focused on LGBT plus people, or you see gendered language or non-inclusive imagery or language on your websites, ask the questions of the person who is responsible for that, and get it changed. And then my final slide is just our contact details, I think. So we're always really keen to hear about the good work that's happening around the country, to promote it, to connect up with other people, formal and informal networks, peer learning. So if you want to, and to help if we can in any way. So if you want to get in touch with me or my team, that's our email address. And if Twitter's your thing, myself and my colleague Lizzie, who I work with, are both on Twitter. If you want to join us there, we have a monthly newsletter that both updates on the work that our team's doing and also shares information from other organisations, both NHS organisations and voluntary sector organisations, you know, conferences, meetings, publications, that kind of thing. So if you'd like to sign up to our newsletter, you can email us at england.lgbtadvisor@nhs.net. And that's it. So I will stop and happy to take any questions. I was stunned you're in silence.
Dr. Brady, I don't know if you can open the Q&A from your view of Teams, but we have got some questions.
Hold on, maybe it's buffering. Oh yes, I can. Sorry, here we are. Okay. Okay, so shall I just go through these? So can everybody see these? I'll just read them out. So what do you think about the equalities questionnaire we are often asked to fill out when accessing health can make individuals feel unnecessarily outed and as a result feel more vulnerable? For example, someone could be accessing a service but then feel the outcome of that service might be affected by their declaration. I'm not saying this is a hard and fast rule for all, but do you agree how this can happen? If so, what steps would you take to help address it? So yeah, absolutely. Thanks for that, Chris. That definitely can and does happen, and I think that definitely speaks to the fact that LGBT plus people don't have confidence, you know, in establishment or in organisations, and are concerned and do feel vulnerable and might feel either unnecessarily outed, or might feel that there would be a negative impact of them being outed. That's why people are not always confident being their true selves at work and don't answer those questions in workplace surveys, and similarly for patients. So I think, so one of the things, some principles: one, these questions always have to have a prefer not to say. So, you know, you're not forcing anybody to answer the questions. And interestingly, when you look at LGBT plus surveys, and actually it's the same for pretty much most other services, like the ones looking at disability, ones looking at race and ethnicity, often the second after the commonest thing. So if you think about LGBT plus responses, obviously the commonest response is heterosexual and cisgender. After that, the second commonest response by quite a long way is prefer not to say, and then people who are confident to talk about their sexual orientation or their gender identity. So we've frequently in the experience surveys, the people who say prefer not to say, when you analyze that group, they're actually the ones who have the worst experience. So that's the kind of lack of confidence I think that you're talking about there in evidence in the surveys. So how we address it, one, you've always got to have a prefer not to say. Two, I think it's really about communicating, and this also has to sit with the staff who are doing the survey or the people who are putting the survey out. They have to be able to be confident to explain the reasons for it. And I think we need to always explain when we're asking for personal or sensitive data, why we're asking for the information, how that information is going to be used, very importantly, how that information is going to be protected, who it's going to be shared with and who it's not going to be shared with, and then also feed it back. Don't ask these questions of people and then never tell them what happened to the information that they gave. And I think those are some of the things which will slowly build the confidence, so that people will feel more able to answer the questions. But okay, hope that helps. Next question from Jenny. Do you think that negative attitudes play greatly to the mental health in trans and non-binary communities, and a distrust of the medical profession also exacerbates this? Simply put, yes, Jenny, I do think that, and that's kind of why I always start these talks with that context thing. I don't think we can overestimate the negative impact that the toxic debate around trans issues, for example, the way that they're written about in some areas of the press, and certainly the way that Twitter or certain areas of Twitter deal with it, you can't overestimate how that impacts on already vulnerable trans and non-binary people. And that, as I said, hugely informs their lived experience, hugely informs their mental health and well-being, and hugely builds into that distrust of medical professionals. And I think, again, I showed you some data on that. LGBT plus people are less likely to access services because they distrust medical professions, and unfortunately some of that is real because they've had, well, all of it's real, but some of it is from their own lived experience. They've been to a service and been treated poorly, or they know somebody who's been to a service and been treated poorly, or not unreasonably, the NHS is seen as an establishment institution, and if you don't have confidence in the government or the Equalities and Human Rights Commission or whatever institution you choose to look at, you're going to lump the NHS in with that, and that also feeds into that lack of confidence and trust. So we need to be mindful of that, and we need to do as much as we can to address it by challenging a lot of this toxic language and LGBT phobic behavior, and by setting really good examples and being vocal and visible leaders, which I think doesn't always happen across the system. Right, good question. How would you suggest we can call out poor behaviour, especially in settings where you seem to be the only person willing to? Yeah, that's really difficult, and I appreciate it's very easy for me to say call it out, and I know it's not easy to call it out. And frequently, if you're working in an environment where that behaviour happens, then you've probably got the kind of culture, organizational culture, where you're going to be less confident to call it out. So the way that they kind of, it's a bit vicious circle. I mean, I think, and it also depends a little bit on how confident we are as individuals to do that. It's difficult to be the only person who notices it or is willing to do something about it. How do you do it? I mean, I think, I'd say, there are ways that you can do things anonymously, make it raise anonymous concerns. Either, I guess it would depend on the setting, whether that's within a department or within a line management structure, or to your organization, perhaps through HR, or through, you'll all have sort of complaints procedures and whistleblowing procedures and freedom to speak up guardians, and there are routes in to do things where you can, your anonymity can be maintained. I think the other way is if you have allies or know of allies that can support you in doing that. So if you've got an LGBT plus network, or I know someone who's out as an LGBT plus leader. Can you contact them and say, look, I'm having this difficult thing. Can you help with it? Help me with this. So I suppose it would depend a little bit on the circumstance and where it's happening and what it is. And if you're not comfortable or confident to be that person, particularly if you're the only person, find ways that you can do it anonymously, or find allies or routes that can support you to do that. Right. Oh, here we go. Just question, comment by email. Oh, thank you for that. Can you let Michael know that the slide with the first 10 trucks in the pilot were listed wrong? The Queen Elizabeth Hospital is in Kingsling, Norfolk, not Birmingham. Apologies for that to the county of Norfolk and to Queen Elizabeth Hospital itself. You're absolutely right. That was written in haste, like many of my slides. Birmingham Hospital Trusts are now in it. They've just joined the wave most recently. So thank you for that. Whoever sent that comment in, I will make sure I address that and never show that slide again in its current form. Okay, I think have I done them all? I think those are all the ones that I can see. There's one new one. Oh no. So thanks. Khan's put my Twitter stuff and our email address there as well in the Q&A. Are we done? I think we might be done.
So that's been absolutely fantastic. Thank you so much, Dr. Brady, for that. I think we've all got something from it, and it really helps. I think, sorry, I'm hiding, aren't I? I'm hiding rather than putting myself on. But it's really helpful to get a sense of like the standard of care that we should be aiming for, and the standards that we can achieve to support colleagues as well. And I'm personally going to take a lot from that in terms of challenging norms.
Great. Well, thank you very much. Thanks for the invites. Enjoy the rest of the conference and the rest of LGBT+ History Month. It's great to have joined you. Thanks very much.